So, but I won't take much of your time. In the next few minutes, we'll talk about sorry, I think I mistakenly pressed leave the meeting for my
let me
in the next few minutes, we'll be talking about antepartum hemorrhage. So we have to know, because bleeding in pregnancy is not a normal event at any point in time in pregnancy, whether being it early gestation or in advanced gestation. We'll talk about third trimester. But by and large, once we have a bleeding process before the age of viability, we refer to as a miscarriage process. Whether threatened miscarriage, threatened miscarriage, inevitable miscarriage, incomplete, complete, any form of bleeding at age less than age of viability, we'll call it miscarriage. So we now have different types depending on which one we are dealing with. However, by the time you have a bleeding beyond age of viability, then it terms antepartum hemorrhage, because at that point, baby is already viable. And for this our environment, we use 28 weeks at the age of viability. However, we have to know that in advanced country, some use 22 weeks, some 24 weeks, even, and also WHO classify miscarriage at age 500 grams and below. So if you deliver 600 grams, even at 24 weeks, so it's viable in some environment. However, because of the prevalence of our environment, our neonatal care, and our salvage rate, we usually use 28 weeks as our age of viability. So when you talk about antepartum hemorrhage, you talk about bleeding from genital tract beyond the age of viability, and also before before delivery. So it has a lower limit and also upper limit. So doctor have said that any bleeding in pregnancy is alarming, either being in fourth trimester or second trimester, may be inconsequential or serious, depending, must always be taken serious. Any woman that presents with bleeding, pregnant woman, you have to investigate and take it serious to actually know the cause and treat appropriately. It increases the risk of premature delivery. Yes, all over the world, about 500,000 maternal deaths annually occurred, and these are due to what? Obstetric hemorrhage. Obstetric hemorrhage, basically, we talk about both antepartum and postpartum hemorrhage. Maybe in our next lecture, we'll talk about postpartum hemorrhage, but today we are talking about antepartum hemorrhage. Maternal mortality ratio in Nigeria is still very high. It's still between 800 to 1.5 per 30,000. These are, but which is very, very high. But averagely, is about 5.46. But that is very high compared to other advanced countries that is less than 70 per 100,000. Then 25% of maternal mortality in Nigeria is due to hemorrhage. That is antepartum and postpartum combined. So then talk about the, okay, sorry, as I have a slide, talk about antepartum hemorrhage generally. We have the, not everybody that is bleeding in pregnancy that is due to obstetric cause. We have obstetric cause of antepartum hemorrhage and non-obstetric cause of antepartum hemorrhage. The obstetric cause are the commonest one. The commonest one include placenta previa, abruptio placentae, you can even have vasa previa and all. We also have some causes of bleeding during pregnancy that are not due to obstetric condition. What if someone had a local trauma or a local disease on the cervix, cervicitis, even cervical cancer? Some people get pregnant or women in cervical cancer. What of cervical trauma? So these are things that can cause bleeding during pregnancy, but they're not obstetric cause. So they are obstetric cause and non-obstetric cause. So what I was trying to say is that the commonest one is obstetric placenta previa. So that's why I'm starting with this. I think there's a slide before this one where I listed those ones, but maybe before we upload it, I will edit it. So placenta previa, when we have in placenta, naturally, it contains maternal blood within the intervillous space. If you look at the placenta, there's maternal aspect, there's fetal aspect. The maternal aspect contains there are some intervillous space where the maternal blood circulates. Fetal and maternal blood does not directly mix during pregnancy. However, there's exchange of vital nutrients, oxygen, and other nutrients are exchanged at the placenta bed during some form of diffusion and osmosis. So that is what I was saying. Then where the placenta is adherently adhered to the maternal uterus, so there is intervillous space there where the maternal blood filled. Where they also have decidual space remain intact as long as placenta is normally situated. During effacement, dilatation, during the effacement and dilatation, chorion separate from the attachment of the mammary, causing mild bleeding, called show. And also, when a woman's some of the signs of labor called a show. Show means some cervical, because during pregnancy, to prevent ascending infection, immediately a woman gets pregnant, before around 10 weeks, 12 weeks, there's what we call cervical plug or mucus plug. It plugs the cervix. This seals the entrance of the womb to prevent ascending infection from the vagina, because the vagina is not sterile. You understand? Is vulnerable to exterior. The anus is there, the urethra is there, and doing intercourse and all those ones. So on its own, it has a way of settling itself. But during pregnancy, the cervix is sealed by a mucus plug after from like 10, 13 weeks. But during labor process, this mucus plug is being dislodged. And during the process of dislodgement, there's some small bleeding that will occur. That's why some, madam, I've seen some catarrh with blood. That is the typical way they describe it. That is what we call show. So some people, this show can be heavy. Some say, I started bleeding, no. Whereas it was a mere heavy show. So, but you have to really evaluate to exclude other form of antepartum hemorrhage. However, then if the placenta is inserted in lower segment, it's heavier. So that's what we call placenta previa. So as I've said earlier, definition of antepartum hemorrhage, antepartum means bleeding beyond the age of viability up to delivery. Normally, a woman is not supposed to bleed. Even during labor, you're not supposed to bleed. This is after delivery of the baby, then you not deliver the placenta. But anything that happened before delivery of the baby, any bleeding is called antepartum hemorrhage. I've said earlier that in advanced country, 22 weeks is regarded as the age of viability, some 24 weeks, understand? But in our environment, we use 28 weeks. Then the causes, obstetric cause, just as I've said earlier, bloody show, placenta previa, and abrupt show, vasa previa. Then other conditions like disseminated intravascular coagulopathy, uterine rupture, marginal sinus bleed, vulvar varicosis. Those are not common. The two highlighted ones in bold are the most commonest one, placenta previa and abrupt show. Then you also have the non-obstetric cause, cervical cancer, cervicitis, cervical polyp, cervical erosion, and condyloma acuminata, vaginitis. These are things that are not related to pregnancy, but they can do occur. Even this one can occur in non-pregnant states, and they can occur in pregnancy. So let's take the commonest one, placenta previa. It occurs when the placenta is wholly or partially located in the lower uterine segment. Usually, placenta is not supposed to be situated or developed in the lower uterine segment. Usually, the other part of the upper segment, the funda, the posterior, anterior, but it must not be lower, because the uterus has the lower segment and upper segment. The lower segment is thin and is usually collagenous, but the upper segment is thick and is muscular, and that is when the contractions start from. So that is the normal place where placenta is supposed to be separated, especially in pregnancy. As pregnancy advanced, the lower segment, the uterus stretch out, whereas for men are making the lower segment to be well formed, especially as the woman approaches term. Then I just have said that when placenta is located either partially or wholly in the lower thoracic segment, it's called placenta previa. Then we have different types depending on how close it is to the cervical os, or how close, or how the relationship of the placenta to the lower thoracic segment and cervical os. In type 1, it's just easy. The placenta is located in the lower thoracic segment, but does not reach the cervical os. Usually, if placenta is within less than 2 cm to the os, we say it's placenta previa. Usually, placenta is supposed to be away from the cervical os, at least 2 cm and above. But by the time it's less than 2 cm, it's placenta previa. So in type 1, the placenta is just in the lower segment, but does not reach the internal os of the cervix. In type 2, the placenta has reached to the internal os, but does not cover it. We call it marginal. It just covered it. It just reached it at the edge, but does not cover this internal os. Then we have 2 types here. We have the type 1 and type A, type B. If it's anterior, it's type A. If it's posterior, it's type B. That is the only one that has subdivision. The rest is just 1, 2A, 2B, 3, and 4. So it's only 2 that has subdivision. Anterior is 2A, posterior 2B. Then type 3 is when the placenta covers the internal os, but asymmetrically. That means it covers it at full cervical dilatation, it moves away. But type 4, when the placenta completely symmetrically covers it, even at full cervical dilatation, like something is sitting at the center of the cervical os. So these are the basically the type of placenta previa. Then classification is purely descriptive. Diagnosis never made by VE. Low light placenta is in the lower segment but far from the os. This classification has a limited prognosis value, all associated with life threatening. So what this one is trying to say is that in this classification, there's also what we call major placenta previa and minor degree placenta previa. Type 1 and 2A is read as minor, while type 2B to 4 is read as major. The reason being that some people are saying, okay, you can allow the minor one, the type 1 and 2A, to go to deliver vaginally if there's no bleeding. Whereas type 2B and above is major, you go for cesarean section straight. However, in a symptomatic placenta previa, even though if it's type 1, the management is cesarean section. Don't say, all type 1 must deliver, all type 2A must deliver vaginally. No. That we can allow them in some instances if they come in labor, they are not bleeding and all. But a type 1 that is bleeding, symptomatic, you still have to go there, because the type does not really mean if type 1 can bleed so much and can lead to mortality. So what are the predisposing factors? Because during implantation and development of placenta tends to develop or attach in a fresh environment, we call it virgin endometrium. Anywhere the placenta has implanted before, in the next, there will be some, because after detachment, there will be some healing by scarring and fibrosis. In the next pregnancy, the placenta tend to move to another place to insert. So that is the tendency of placentation. So imagine in advanced maternal age, the reason where advanced maternal age is a predisposing risk factor is because with advanced maternal age, there's likelihood of grand multiparity or multiple multipara. Maybe someone that's like advanced most likely will have developed given birth severally before, except someone that didn't start family size early. So this number 1 and number 2, they are related, and spelling. Because of the one has been getting pregnant repeatedly, the first one they attach here, second one attached in the first place. A time will come, there won't be in a fresh space for the placenta to get attached at the upper segment. And they had no choice than to move to lower segment. So that's one of the risk factors. Previous uterine surgery, they also have said that anywhere there is scar, the placenta tend to move away from there and go to a fresh place. And if everywhere is scar, maybe from surgery and all, placenta tend to go down. Intrauterine synarchy, because of addition, multiple pregnancy. Because multiple pregnancy, there's large surface area. Imagine 2 placenta. A patient, woman carrying twins, having dichorionic, diamniotic, the placenta is big. So they occupy a large area. There's tendency that the thing might extend to the lower segment. abdominality of endometrial vascularization, prior trauma to the endometrium through D&C, previous history of placenta previa, smoking. These are risk factors that occur. Then how do they present? Usually they have this painless bleeding, painless vaginal bleeding. In most of the cases, they will just come, they just woke up and just saw blood everywhere without any provoking event. No pain, no trauma, they just start bleeding. And most of the time, patients may not have what they call warning bleed. Maybe during the early stage of pregnancy, they just stop spotting or bleeding. That means the placenta is low lying, and any little or micro trauma or something, medicine will just try to shed away. So painless vaginal bleeding, and uterine contraction. Yes, sometimes they might come with uterine contraction, especially someone that have preterm labor or some uterine irritation. Because the placenta is there, any small contraction, they tend to bleed in some cases, but most of the time they come with painless bleeding. Then sometimes they can also be incidentally during cesarean section. And yes, so that's at the point we just go for CS, you just find placenta previa. Probably the scan you did not pick it or so, or missed. Or even incidentally during scan, you just went for doing return scan, you now detect placenta previa. This is one of the presentation. Warning bleed, as I said earlier, warning bleed, these are micro bleed that are caused at the early stage of pregnancy in patients with a low-lying placenta. Then bleeding may reoccur or unprovoked. Bleeding usually severe after 34 weeks. Yes, if you see a woman with placenta previa, yes, the more they have the warning bleed, the more the severity increase, or the more severe it becomes. Yes, due to progressive stretching of the lower segment, they tend to detach and bleed. How do they make diagnosis? By history, just have said, history of warning bleed, history of painless bleeding, previous history, just multiparity, all the risk factors we listed. We start to from the history, we can suggest, or we can diagnose, not even confirm, but at least we can suspect placenta previa. Then also most of the time they present in anemia, in shock. Then on examination, usually the abdomen is soft, unlike the other type of antepartum hemorrhage, which is an abdominal placenta, where the uterus is hard and all. But usually it's soft, no tenderness. Fetal heart rate is audible because the bleeding is from maternal. In abrasive placenta, in placenta previa, the bleeding is more of maternal blood. As the thing is sharing all the blood in the intervenous space, they are more of maternal. That is why the baby might most of the time be normal. And that maybe except if the bleeding is so severe. But at the early stage, the baby fetal heart rate will be normal. But unlike the other type, which is abrasive placenta, where the bleeding is of fetal origin. Then free-floating placenta parts. What it means is that they present with abdominal lie, abdominal presentation, vaginal bleeding. Then when they come, a woman that comes with bleeding, please don't do vaginal examination first. Do scan to rule out placenta previa, because if you do vaginal examination, you provoke more bleeding, and the woman might be torrential, and that might lead to mortality. Then ultrasonography is the most common and most convenient method of placenta localization. Transvaginal is safe, and also transabdominal. Magnetic resonance imaging is also more precise, but no need of full bladder, and is expensive, not really common. Imagine someone coming with PV bleeding, you are talking of MRI, but it's one of the gold standard. That is one of the things we can also use. How does it manage? Depending on the management, depend on the gestation and also the clinical condition of the patient and the clinical state of the baby. So you have to look at the gestational age of the patient. What is the status of the woman? Is she stable? Is there ongoing bleeding? Is the fetus in distress? So there are so many things to look at, but there's room for expectant management, which is the popular McAfee regimen that we do. And there are criteria for embarking on McAfee regimen. And also there are some facilities that should be on ground before you can say a McAfee regimen ought to be instituted. For example, a woman that have minimal to moderate bleeding, but the bleeding has stopped as at the time you are seeing. But in the patient that is having ongoing bleeding, you have to intervene. But maybe there was history of mild to moderate bleeding, but at the time you are seeing the patient, there was no bleeding, and there's no the maternal condition status is stable, hemodynamically stable. Fetus, there's no sign of fetal distress. You can admit this patient and manage expectantly. And expectantly, these are things you do. You have to admit, there is a component of McAfee regimen now. You have to admit in the patient that has in the center that have 24 hours cesarean section care that can offer cesarean section at any point in time in the day or in the night. And also in the center where we have neonatal ICU, because if you want to deliver the baby preterm. And also in a center where there is available of 24 hours blood services. So these are things, conditions that you have to do. Another thing you do, you give another corticosteroid, you optimize. So these are things you have to put in place. So the aim is to prolong the pregnancy to as close as term as possible, because the earlier, the more close to term the baby is, the better for the baby survivor, and other complications of prematurity will be avoided. Yes, it's introduced. This McAfee regimen was introduced at the Royal Maternity, Belfast, in early 60. It involved admission to a fully equipped and staffed maternity unit with blood bank facility as well as theater facility on a 24-hour basis. You don't admit McAfee regimen in the primary health care. You don't admit McAfee with the secondary health care where the lab closed by 6 o'clock or the theater does not work at night. No, a place that can offer all these blood service, neonatal care, and theater services 24 hours. And where you do full blood count, UCR, then you optimize the patient. If the PCV is less than 30%, then it's also what you minimal ambulation. Patient will be on bed rest, maybe with bedroom privileges, just to go and take a bath or ease herself, but not to be walking up and down. Then at least it's 4 units of blood. If you admit a patient, there will be a 4 units of blood at every point in time in the blood bank. This is not when the woman, because the woman can start a torrential bleed at any time. So you have to be a blood must be in the bank, at least 4 units of blood. Yes, you can give tocolytic beneficial, especially if you are trying to achieve, you want to give corticosteroids, you can give tocolytic. Sedation is not required. Fetal kick chart, yes, to be monitoring the baby every day. CTG if available, check pad regularly, and another corticosteroid will be given, yes. In developed world country where ambulance system network, one can manage a sad patient, but this one is not for our environment. All plasma previa symptomatic are admitted in our ward, in the ward. Then this is the first part I said is expectant management, and I've told you the patient that qualify for that. Patient that has mild to moderate bleeding, history of non-blood bleeding, but as time you are seeing, there was no ongoing blood loss. Patient, there's no sign of fetal distress. Woman is mechanically stable, even though not stable, but you have optimized and also preterm. These are things you can consider. But if you see a hemorrhage at term, why there's no need. You have to deliver the woman, whether she's actively bleeding or not actively bleeding. Once at term, you deliver the woman, and also if the bleeding is ongoing, there's in respect of gestational age, a woman that is continuous that is still actively bleeding, then you have to also deliver. Yes, deliver the cesarean section. I underline that the cesarean section is delivery method of choice in the previa. Pre-operative, you do PCV, you go back consumer 4 units of blood, anesthetics, and all. And you also the CS is done by senior consultant available. Then also know that there's indication to terminate McAfee regimen. If a woman is on expectant management, once you reach term, you terminate, as I said earlier. Once the sense of vital distress, you terminate. Once the woman starts bleeding, torrential bleeding, you terminate. So this is once there is IUFD, you terminate. Once there is rupture of membrane, you terminate. So in fact, IUFD is not supposed to even occur, but when there is sign of fetal distress or fetal compromise, you terminate. So these are the indication for termination. So the other aspect is abruptio placentae. What is the definition of abruptio placentae? Is premature separation of a normally situated placenta. The other one is that the placenta was not situated normally, was in the lower segment. But this one is normally situated. but there's a premature separation. Usually, separation occurs after delivery. Placenta separate after delivery. But if you separate before delivery, it's abruption at any point. So premature separation of placenta after the age of viability. Again, you have to, if it occurred less than that, we call it the miscarriage process. So almost always result in perinatal death. So if care is not taken, if intervention is not done early, because what? The blood loss is of maternal blood. The incidence about 0.5 to 0.5% for all pregnancy. Yes, there's different type. It presents in, we have revealed abruption, we have concealed abruption. Sometimes we can have mixed. Revealed abruption means the woman is bleeding outside. Maybe there's a separation and the blood tracks down. The woman is bleeding externally. You can see the woman complain of bleeding. But sometimes the woman will not complain of bleeding, whereas the woman is bleeding internally and the blood is concealed at the back of the placenta, between the placenta and the uterus. You will not know clinically, you see that the woman is just happy because the woman is just pale, or fetus just die, or maybe so many complications, woman can even enter shock, so many things. So that one is, in fact, that one is more dangerous because if it's revealed, the woman will quickly come to hospital. Doctor, I'm bleeding. But in a concealed one, sometimes they might not come, maybe they might come with complications, either with anemia, shock, or even the IUF. You can have mixture of both. Then classification, yes. The classification of abruption placenta is based on, number one, PV bleeding, the severity of PV bleeding, the maternal status, and also the fetal, present or absent of fetal distress. So if the bleeding is minimal and mother is mechanically stable, there's no time fetal distress, is type 1 or grade 1. If the bleeding is moderate and the maternal vital is stable, there is no sign of fetal distress, is grade 2. But by grade 3, by the time we're not having in grade 2, there's already form of fetal distress, but in grade 3, there's severe bleeding, there's mother is hemodynamically unstable, there's intrauterine fetal death. That one is grade 3 already, which also have sub-classification 3A and 3B. So when we have coagulopathy, is 3A. Without coagulopathy is 3A, but when we now have IUFD plus DIC complication, is 3B. So just for you to know this classification. Then what are the etiology? Yes, some clear. When you have previous history, most of the things in obstetrics and gynecology, once you have a previous history, the tendency that the thing might reoccur again. When we have a previous history in a patient that have hypertensive disorder, because hypertensive disorder, because of the high blood pressure in the blood vessel, even at the maternal bed, at the placenta, at the uteroplacental bed, they might be bleeding, and this could lead to separation. So when we have issue of trauma, can also cause advanced maternal age, advanced priority. So there are other things that have been shown. Maybe people with low socioeconomic status, people with poverty, malnutrition, because they tend to have probably not having care. And this set of people they are prone to multiparity, some disease in pregnancy that they're not taking care of. So these are things. Also, that I've said of folic acid deficiency, cigarette smoking, it might affect the integrity of the small arterioles and the arteries at the placenta bed. Short umbilical cord, which could cause a tugging on the placenta to separate. That causes consumption, cocaine use, fibroma. These are things that have been proposed as risk factor, but the most common one that we see in the environment is hypertensive disorder of pregnancy. So this is a pathology. Just for you to just take a look at it. There's uterine vasospasm occur first, followed by relaxation and vascular engorgement. Can you see now? Then there's arteriolar rupture into the decidual bisalis. Because of that's something that the most common cause in the environment is hypertensive disorder. Because of the hypertensive disorder, there's rupture of the arterioles into the decidual bisalis. decidual hematoma is formed with eventual decidual necrosis at the edge of the placenta. As blood escapes from under the decidual vitellis, it dissects under the membrane and can break through. So these are some of the things and how it leads to DIC because as blood is bleeding, there is consumption of the coagulation factor. That is why abruption placenta is what is a consumptive it leads to consumptive coagulopathy. All the blood clotting profile will have to go there to stop the bleeding. Eventually they will be overwhelmed and coagulopathy will occur. So you can just read this slide and this page and see. Then what they present? They present, yes, in terms of PV bleeding, similar to plasta brevia. However, unlike in plasta brevia where the uterus will be soft, not tenderness, but here patient will most likely have tenderness because the one is bleeding. So the uterus it will be woody hard, sometimes very strong, and then there will be sudden abdominal pain, and with no bleeding in the conceal, sometimes with bleeding in the review type. The patient might present with shock, anemia, and also woody hard uterus. Just as I've said, because the bleeding is escaping to the myometron, then usually fetal demise, because I've said that the blood loss is from the fetus. Fetal part not easily palpable because the uterus is very hard and strong. Then posterior ruptures, if you get backache, BP might be low or normal, depending on when it was picked. So diagnosis is usually clinical. Then differential uterine rupture, previa can be a diagnosis, but by the time you do scan, you should be able to know. By the time you rule out previa, and with all these features that we see, with all these clinical features, it's usually things that we can suspect. Complications I've said earlier, anemia, leading to anemic heart failure. Patient can come in shock. Patient also can cause renal failure because of the shock, coagulopathy, and PPH because of the COVID low uterus they used to have. Blood is seeping into the myometron. So even after the delivery, there might be difficulty in contracting to occlude the spiral arteries. So they might lead to PPA. So any patient that has abruption placenta, you should watch out for PPH. And also complications can lead to hypertension because most of the time is pregnancy due to hypertension or hypertensive disorder in pregnancy that leads to this. Then eventually the patient might even develop chronic hypertension. The management is prompt. If the management is, because they normally come in a bad state, especially people that didn't present early, they will come in shock and all. What the main thing is that it's an obstetric emergency. In fact, even previous to an obstetric emergency, and you call for help in emergency case, and you institute ABC of resuscitation. You make sure the woman is the airway is there, the woman is breathing and circulation. You set white bulk cannula, take sample, then you do other practice volume, start transfusing, you get first positive plasma, you catheterize, you monitor and all. There's a room for what they call mild abruption. Maybe the woman just had issue of bleeding, mild, the fetus is still no fetal distress, no active bleeding, you are full of previa, and it's preterm. And you want to maybe see if you can manage this patient expectantly or conservatively by giving natal corticosteroids and see if you can add some days. There's room for that, but then you have to be very, very cautious because you can lose baby at any time. Then the management is usually, if the fetus is alive, we call it abruption plus live baby. It's a very ultra fast cesarean section. We call it crash cesarean section. The CS must be done within 20 to 30 minutes. In fact, it can be even done within 15 minutes because as the woman is bleeding, the baby is turning to anemia. The chance that baby will have mobility is there. So abruption plus live baby is an indication for emergency cesarean section. But if it's with IUFD, there's no point again. The baby is already dead. You can rupture membrane and titrate oxytocin and allow the woman to deliver vaginally. Except if there's torrential bleeding, even despite the IUFD, you can't leave the woman to die. If there's bleeding that is, you can't wait for this woman to go through labor 4 hours, 5 hours, augmenting her, and she's bleeding, so that she won't bleed to death. In some cases, even with IUFD, you can still take for cesarean section. But usually, with IUFD, you allow vaginal delivery. With a live baby, you go for cesarean section and save the baby immediately. Then other form of APH is vasa previa. Vasa previa is just simply means occur in a situation of abnormal placenta or umbilical cord insertion. Usually, the umbilical cord, the allantoin, they are all from the midpoint usually from the center of the placenta, then to the umbilical cord of the baby and it happen. But in sometimes where we have what we call filamentous insertion of the umbilical cord, where instead of the placenta, instead of the umbilical cord to arise from the center of the placenta, is now going to the edge. Maybe it's in form of aberration during development. Then go to the edge in such that the covering of the placenta of the umbilical cord is covered by water jelly or allantoin, and all. They are not, the umbilical arteries are now exposed because of some defect or some aberration or due to defection in insertion, so that by the time, if this is not noticed, by the time you rupture membrane, you are likely to injure the umbilical vessel. So that is why vasa previa is a case that immediately you rupture the membrane and you see bleeding. If you rupture membrane and you see bleeding, fresh blood, and you check your fetal heart rate and fetal heart rate is going down, it's most likely vasa previa. And because the volume, maybe the volume of the blood is very minimal, a little blood loss from the baby can cause great hemodynamic stable. So most of the time, they even end up in IUFD. So the best thing is to detect it before labor or even before rupture membrane, and just quietly and do your cesarean section. But except in the situation where cesarean section can be done in less than 10 minutes or 15 minutes. If not, imagine a bleeding from the umbilical cord or umbilical vessel from the baby, and you say you are praying for cesarean section. The baby will lose it because the baby does not have enough. The baby's body volume weight is small. Maybe the blood volume in the whole baby is like 200 mils or 240 mils, depending on the weight of the baby. And baby's already losing 50 mils, 100 mils. To you, it might be a small blood, but to the baby's already losing more than half of his or her blood volume, and baby might lead to death. So vasa previa is, though not that common, but it's something you have to know at the back of your mind, that anytime you rupture membrane and you see bleeding and you see that there's fetal heart rate abnormality, you have to suspect vasa previa. Then that is what. Thank you. Though, as I've said earlier, the other cause of antepartum hemorrhage is a non-obstetric cause, so I didn't really talk about that. Then is the obstetric cause that I talked about, and the main thing is there is the plaster previa and abruption. So sorry, I will have I'll bring some questions on plaster and APH so that we can use it to remind ourselves. But read this slide. Maybe in our next lecture, before we even start the lecture at all, I'll bring like few MCQ questions on antepartum hemorrhage, few, so that we'll just use it to remind ourselves before we proceed. Thank you very much for your time. So at this point, if you have any question, clarification, or comments, you can proceed. Sorry, for this purpose, sometimes we need to identify you by your name. Please write your name on, identify your device. Because I'm seeing two, it's only two of you that join, Scarlett and T. So Scarlett, please, what is your name? Identify your device so that we can call you properly. T, you are there? What is the...
Yes, sir. Good evening, sir.
Good evening.
My name is Tokwe.
Okay, Tope, any clarification, any question?
No, sir.
Okay, all right. So please identify your device maybe next lecture. You
Okay,
label
sir.
it very well. Then Scarlett, you can unmute yourself and okay, Agnes. Scarlett has hello, Agnes. So I think she's trying to speak, but our network is not seems not to be strong.